hello. So I get the honor of introducing Dr. Justin Peterson. So Dr. Justin Peterson is an OB-GYN at Coffee Regional Medical Center in Douglas, Georgia. He is a triple bear, receiving a Bachelor of Science in Biochemistry and Molecular Biology from Mercer University undergraduate, a Doctor of Medicine from Mercer University School of Medicine, and completing his OB-GYN residency at Navicent Health in association with the Mercer University School of Medicine. He continues to be an active Mercer alum as a clinical assistant professor and sitting on the Mercer University Admissions Committee, as well as serving as a board member for the Rural Health Innovation Center.
Good afternoon, everyone. I will be introducing Reverend Paul Byrd. Reverend Paul Byrd serves as the chaplain at Children's Healthcare of Atlanta. Prior to that, he served at Mercer University and directed a collaborative program between McAfee School of Theology and the Georgia Rural Health Innovation Center at the University of Mercer University School of Medicine. This program supported the physical, mental, and spiritual health of communities by coordinating the efforts of clergy and healthcare professionals as they work together to address rural health disparities in Georgia. Before coming to Mercer, Reverend Byrd spent almost 30 years as a chaplain in children's hospitals in Birmingham, Alabama, and St. Petersburg, Florida. He serves on the faculty of the Pediatric Chaplains Institute and is the 2021 recipient of the CBF's Carl Hart Award for Excellence in Chaplaincy and Pastoral Ministry. Paul is a proud Mercer Bear, having graduated from Mercer University in 1989 with a degree in music education. He received his Master's in Divinity from the Southern Baptist Theological Seminary in 1993 and completed his chaplaincy residency at the Emory Center for Pastoral Care in 1994. Everyone, let's welcome Dr. Peterson and Reverend Byrd.
Paul and I met probably about a year and a half ago. He had called me because they were looking at integrating medicine in religious beliefs and how we kind of integrate that. So Paul called me and they were looking at having some medical students come down and see how faith and medicine work together and do some work in that. So obviously for me, my faith in medicine go hand in hand. I can't separate the two. I believe that my beliefs that Jesus Christ died on the cross for my sins integrate into my medicine every day, and how I do that. And I can't separate those two. And so obviously I told Paul, absolutely, I'd love to. So through that, we began talking about how our fields kind of come together and how we basically can use religious organizations, religious beliefs in medicine, and how religious organizations can use medicine in order to help what they do every day. And so today we wanted to kind of have an open conversation and have more of an informal conversation about how we kind of go along that, but specifically in regards to loss during pregnancy. It's one of those conversations that's extremely hard to have, hard to kind of go through that with patients. Whenever we have loss, there can be loss at different times during pregnancy. We deal with it a lot with miscarriages early in pregnancy in the first few weeks, and then you also deal with loss throughout pregnancy. Sometimes those can be things that we know are coming, sometimes we don't, sometimes it's a complete surprise, and how we deal with that process. As clinicians, a lot of times our time is very limited with patients, and so we see these patients, we have to give them a diagnosis, we have to tell them, options that we have to kind of move forward, and then, in that same moment, try and assess how they are doing emotionally, how that emotion is carrying into, their beliefs and to their family and throughout their whole life. Whenever I have moms who have losses very early on, in that first trimester, a lot of times I sit down with them and, I express, my condolences. And a lot of times, my conversation with them is that it's not their fault. It's nothing that they did wrong. That 1 in 5 pregnancies end in a miscarriage, and that's something that we don't talk about very often. It's not something that you see on Facebook. People don't go out and shout to the world that they had a miscarriage. A lot of times it's very personal. A lot of times their support system, they don't even know that they're pregnant sometimes. And so it's a very personal and intimate thing, but patients carry that, and they carry that through future pregnancies. They carry that throughout their life, and how they view the world, view their relationship with religious leaders, with their belief system. I have some really good friends that we went to a murder mystery together, and they were very early on in pregnancy. They didn't even know they were pregnant, and they're holding it so they don't believe in drinking any alcohol. And it was out of laundry, and they had like a slushy machine, and she drank a couple of sips of it before she realized they had alcohol in it. And later she had twins, and unfortunately lost one of them. And she carried that throughout the whole pregnancy. She still deals with that today. And it's something as a clinician, a lot of times I wouldn't even connect that. That their beliefs, their religious beliefs, had such a strong conviction that they still blame themselves and hold that. And we've had conversations with it. I think it's important to realize that, and to realize the impact that their beliefs can have. I also think it's important to realize as we kind of think about this, what it means for future pregnancies. I had a young lady whenever I was in residency that came in that unfortunately would have broke at 18 weeks. She came in, we had the conversation that she's at risk for infection, that she's at risk that this baby's not going to make it, even if it does make it, it's going to have severe complications with contractures, and had that whole conversation. And she looks at me with tears in her eyes, and she's like, I can't give up on my baby, and that's her feelings on it. And I sit down and pray with her, and throughout the entire time they were there, I saw her, I would go in, I would pray with her. They were a very religious couple, and unfortunately she got chorioamnionitis and got an infection. And at that point, it was a decision that we had to make. It was life or death for the mom, because she was going to die. And I still remember to this day going in and praying with them beforehand, saying, listen, this is the best thing for you, the best thing for what's going on, and giving her medicine in order to induce her labor. And I still remember whenever the baby was born, holding the baby, giving it to them for a few minutes, just for them to spend a small amount of time with the baby, with taking a slice of breast. And it was about 2 years later, I was still in residency. She came back in, and she came as a patient, and she was like, I remember you. You prayed with me whenever I lost my baby, and I wanted to show you this baby. Like they had another one successfully. And I think it's important as we deal with patients with loss, to be vulnerable with them. A lot of times as clinicians, we get jaded. It's very easy to in the system. It's easy to look at the lack of resources. It's easy to look at hospital administrators who push numbers and push, you've got to see a certain number of patients and provide. And a lot of times we lose the rawness that should come with what we do every day. And that's one thing that I love about OB-GYN is that you are part of these people's lives at their most vulnerable times. And sometimes that isn't the best part of their moments in life. Sometimes it's in the worst parts. And that transcends even years down the road. Personally, my wife and I, we've got 2 beautiful boys, and we wanted to have another child. Unfortunately, fortunately, we got pregnant, and unfortunately, my wife lost a baby very, very early on. But we were pregnant at the same time as some of our friends. We were excited. You have that initial excitement that we're going to grow up together. This is one of our best friends from pre-K. It's like, oh, we can grow up. Our kids are going to grow up together. and then we lost others. And, you know, in that moment, you're sad, but even now, you know, I look back at his child that is, you know, 3 now, 3 or 4, running around, and like I still have that sadness, you know, and it's, I think as clinicians, as providers, we have to realize that that carries through. And a lot of times, you know, we have a very small amount of time with patients. And so, you know, one thing that Paul and I have talked about is how do we kind of bridge that gap? How do we bring in other resources in order to support those families, to support those moms, to support those dads that are going through those losses, and how ministers can do that. You know, another thing that we kind of do a lot in our hospital is whenever we have a loss, especially a late trimester loss, is that we try to take pictures of the baby. You know, we make footprints with them, because one thing that we know through research is that moms and dads, families who could go through this, one of their biggest hurdles that they go through is the loss of memories. That you know, once they hear your baby doesn't have a heartbeat, that the world stands still. You know, nothing else matters. They go blank. They can't think of anything. And so that's why, you know, as clinicians, sometimes it's hard because we have to tell these patients this, and then it's, okay, well, now we've got to move on. We've got to get this baby delivered. You know, you tell somebody at 36 weeks that baby doesn't have a heartbeat, they've already had a baby shower. They've already painted a nursery. They've already, you know, planned out how the delivery is going to be, and we just shattered their world. And then in the next breath, we have to sit down and say, okay, now we've actually got to deliver the baby. And it's really difficult to do. It's difficult as clinicians to do. It's difficult for pastoral care to come in and counsel them. Because, you know, ultimately they go through the pain of losing the child, and then they also have to go through the pain of childbirth a lot of times. You know, I had a patient not too long ago who she had a pregnancy the first time. She delivered very, very early on. She was 28 weeks at classical C-section, and then came back. She came in to see me at 24 weeks, and they didn't have a heartbeat. I had to tell her that, and then I had to say, okay, now we've got to talk about delivery. And the recommendations is, you know, even if you've had a C-section before, to try for vaginal delivery, and try for vaginal delivery with this lady. And I had her in, she was doing well. I thought everything was going okay. I made sure to kind of talk through the process, talk through what to expect to do. Once baby comes out, we're going to wrap baby up. You know, this baby might not look like a formed baby all the way. We're going to allow you to spend as much time as you want to with the child, and make sure that we're saying, you know, your baby, be respectful of them. And unfortunately, during the process of induction, she actually had a uterine rupture, and you know, I had to go into a C-section at that point, and to save her life because she was bleeding out internally. And, you know, now she recently was actually, even though we told her that she probably should not get pregnant, she got pregnant again. And you know, I had to walk through that with her, walk through that loss. And she actually delivered not too long ago, and successfully had the baby. She actually had another uterine rupture that they were able to catch at the time and save the baby's life. But anyway, that's, you know, the conversation that we want to have is how do we as providers, as midwives, as doulas, as physicians, as nurses, how do we move past being isolated, and what other resources do we have that we can bring in to have this conversation?
Thank you. Hi.
Hi.
I want to just say several things just to state the obvious. For one thing, this is a rock star, and he has been fun to get to know since the first time I called him. And he said, Paul, I want to work however we can together. I've been watching and observing this conference, and I'm just amazed at who's in this room and the energy in this room. So thank you for that. I want to name a couple of things though that are a little obvious to me. You've got two guys up here talking to you about women's health, and the room is mostly women. So I want us to spend a lot of time listening and talking together, because that's what needs to happen. in this place. Also, I want to name that we are talking about, we were talking about grief. And Justin just said that, Dr. Peterson just said that 1 in 4 or 1 in 5 pregnancies end in loss. And I want to name that means that more than one in this room has been through this difficult journey. And so we're talking about holy ground. And so I just want to name that. I'm not sure why I was a chaplain, why I chose that instead of the ministry that I started to train for, which was ministry to music in a church. But I do know this, in 1960, a young nurse with one daughter who had followed her new husband down to South Carolina to take a pastorate, found herself pregnant again. And within the first trimester, her physician, the family physician who she went to see, told her that there was no heartbeat. But they had to wait until her body delivered that baby. The story of the brother that we never talked about until I was in seminary and learned that that was part of my mother's story is amazing to me. And it's amazing to me because I'm convinced that it has threads, that grief, that holding on to something and then not talking about it.
That's right.
Has threads to who I am, but it also was a grief that she never talked about and never processed. And when I was in chaplaincy training in the old folks' home talking to the old ladies, and I would say, what was the most difficult thing you ever experienced? They would tell me about the pregnancy loss or the young baby that they still remember. They have all these grown kids, but they still remember how old that child would be and wonder what they would be doing. This is a very impactful conversation, and it is living in this room, and we don't talk about it much. The death of a child is one of the most difficult things. It is, to use a theological word, ineffable. There are no good words for it. I love that word, ineffable. As a chaplain at Children's Hospital, we deal with death not infrequently. It's not on our billboards. We don't talk about it a lot because it's not something you want to talk about. But there are things that we do, and we think we do it very well. And actually, we do. Justin just named some of those things. It's about meeting parents where they are and being very honest about what's going on and trusting people with that information. About letting them help make decisions with you about how to proceed and make things happen, right? It's about making memory. And we do handprints and footprints. We have little memory boxes. We have music therapists listen to heartbeats and even put music to the heartbeat of their child before they die, if we can. We do all kinds of things like that. We let them hold, and it can be beautiful. We take pictures with babies who died too early, and they're amazing. And I thought it was creepy first time I heard it, but it's amazing. And families really, really value some of those things that they get to choose and invest in. The staff is amazing, and they care for the child. Heck, the staff grieves with them. And if you've ever been in that kind of situation, you probably know what that's like too. You've got to be all in, or hopefully. And I've seen some of the most compassionate care and some of the best nurses and doctors that I could ever imagine. We do all the things, and then we give them a packet of information, and we send them home. And we may be able to call once or twice. We will send cards and letters on Mother's Day and the baby's birthday and at Christmas. and then we have a memorial service. But studies show that even perinatal death, early death, is grieved just like the death of a child. It is normal grief. And in normal grief, what do we know? We know in very normal grief, the intense time lasts at least 12 months. I think 2 years. I've had calls from dads who are like, I am so mad because somebody told me this would be better in 12 months, and I am just now feeling it. But all of our bereavement follow-up, even at Children's Hospital, where we do a really good job compared to most, is for really the first 6 weeks. And then who's checking on this mom and dad? I'm also a person who's been minister at a church. And I'm a member of a church. And I know that at our churches, we do a really good job. Got a lot of minister friends, do a really good job of when we know somebody's pregnant, celebrating with them. If we know there's a problem or a loss, we do a pretty good job of attending to those things. But after the funeral, even when we're trying our best, 6 weeks, 8 weeks later, we don't do a good job of good follow-up. And we know the needs really happen after that, because moms are just starting to figure this out. I love your story, and I'm sorry for your loss, by the way, but I love your story of seeing your friends and still grieving, because those things are still there. So, an earlier speaker said, let's be those elephants who make the circle of protection. I think because there are limitations in clinical care, what do we do at Children's Hospital? How do we be present with moms and dads when they're home 6 months later? I think for Dr. Peterson, one of the things in our conversations he said is, Paul, we do our best, we do good follow-up when they come in. So my question for us, we've been talking for 30 minutes, so I'd love for us to have 30 minutes to talk. My question for us is, how do we reach beyond the limitations that we have or that we tend to have in community to really lean into the needs that are there? Studies show that the most effective bereavement care happens first with family, and family including partner, right? But dad's grief too. Then the next most important seems to be clinical care. It seems to be, how did the doctor explain things to me, reassure me, do follow-up care? How did the nurse and the chaplain, all those folks do good care for me and for the family when they're suffering loss? But then the next best thing is community care. Now, we give out folders of all these resources, and actually I'll have you guys emailed, we didn't put it on the board, but emailed all the resources we send out as Children's Hospital. There's some really good ones, and a lot of them are remote. But really, nothing is like the lady in the church who lost a child, who knows, I'm going to keep in touch with this mom. The dad at the gym who also lost a child and who goes to the father who he knows lost a pregnancy and is present with them. So when we're talking about how to care for each other in community and make community, this is really born out of our work in looking at how does the clinic and the church and the community work together and bridge some of the gaps that are there for us. So given that, have I talked enough? Yes. how can we work together? Because I think that there's a breakdown in golf, and I think it's a pretty interesting conversation. So that, anything I need? Okay. So I invite you to interact with this, and I bet that there's some thoughts and feelings in the room. I do need to say, if you have a question, please wait till there's a mic for you, because they need that for the recording. Okay?
Hello. So my name is Patricia Prime, and I have a nonprofit organization called It Takes a Village Maternal Health Expo. And that's a whole another story, but I'm appreciative of this topic because I'm 60 years old, and my birth mother passed away when I was 21 days old. I was baby number 8 of her children. So as I grew up, I just assumed I was the only baby and everybody else knew who she was. But as I have grown and started to do this work, because I started doing postpartum doula support 5 years ago, and not until I actually started doing the work that grief became my story. And so when I hear people, when we talk about maternal mortality and infant mortality, sometimes I feel like we talk about it at the surface level, but when a baby is left and the community, church, extended family, the the healthcare system, when people circle around those children, I think we just assume they're just kids. And so we can step into those roles and be the mom or the dad that those children need. And so when you're growing up, when you don't hear I didn't hear the stories of who my mom was or what kind of person she was. I just knew the person who raised me was my mom. So as I got older and I would hear people say, that's not your real mom is dead. It didn't, as a kid, that doesn't compute, that don't make sense. What do you mean that's not my real mom? As a kid, I don't understand what they're saying, but now I'm grown, and then I'm saying, that's my auntie, and they're like, that's not your auntie, that's your sister. So it gets confusing, and then now I have children, and then I'm saying, that's your cousin. No, that's not your cousin, that's your, wait a minute, that's your auntie. So what I'm saying all of that to say, from a community standpoint, I think sometimes out of not having the knowledge, we don't know what to do with the children. We just step into those roles and assume that what we're doing is the best that we can for those kids, and you probably are. But there's a hole in those kids that nobody can fill unless we're really being honest with those children and sharing the stories of who that mom was or who the little brother or the little sister was that died, so that when they grow old, they're not confused and they're not trying to figure out where they came from or why am I feeling this way. Because I think that what I went through, it drives me to do my work. So when I'm working with a postpartum family, I'm coming from a whole different angle because I want them to stay alive to take care of their own kids so that nobody else has to do that for them. So the answer to your question, or my response to the question, is we have to do a better job at teaching the community about maternal health and all of the genetics that surround it, because what if that mom dies and that baby is left behind? We have to do a really good job as a village taking care of that baby so that they're not growing up in pieces. And then, they're old like me, 60, trying to figure out okay, what am I supposed to do next? Or who is this? Or what is that? And I'm really kind of glossing over a lot of stuff because I don't have time to tell you about that. But it's been a challenge. But I am just now, over the last 5 years, really dealing with the grief of a mom that died when I was 21 days old that I have no knowledge of.
Thank you. Right here. Could you tell us your name?
Hey, I'm Dr. Elena McClain, family medicine. I actually trained under Dr. Peterson. When I was a medical student, he didn't know this, I was going through a lot, but then when I came in as an intern, I had a baby that was 7 weeks old, and that is my only living child. But the point kind of on this is that how do we help is, I think inclusion, as I think OBs actually do a great job with their patients, and kind of like how our patients as family medicine, they kind of disappear when they get pregnant and they get in with their OB, they kind of disappear to the OB until past that 6 week, and then they kind of come back to me. And then I take care of them until the next pregnancy, or, you know, but they keep kind of coming back to me. I think maybe better communication within our system when they lose, because a lot of times my women, when they come in, if they've experienced a loss, the first time I really find out about it is from them. I mean, yeah, you send me your notes, I know that. But it comes in like a barrage of notes, like when they got their blood pressure checked, or when they got this, you know, their gallbladder out, or whatever, you know. And if it's an early pregnancy loss, it may just be listed in kind of the subjective or something like that, especially if there wasn't complications and they didn't need a procedure. There may not be anything else kind of noted about it. So given that I would love to see more, as Epic and other EMRs become more integrated, is a way to kind of flag and say, hey, this person just experienced this loss, this person just experienced that loss, so that coming in the door, I kind of already know the backstory, and that helps me approach them differently. Like, you know, I mean, this is where we always say as doctors that experienced nurse is wonderful, because, you know, when this person comes in, I remember one of my nurses come to me and go, this person just lost their kid, or the other one going, this person's husband is a police officer and he was shot 2 weeks ago. Like, and she didn't give me that because she's the community gossip, you know, so yeah, that's great. But I mean, a way to get it in the chart. And I mean, I'm coming at this as, you know, a mom, a physician, and somebody who also has a theology degree from Mercer, in addition to a medical degree from Mercer. And so maybe that's a way we can support, is how do we get the communication out, maybe not in a whispered down the hall sense, but actually in the chart, in the communication, and it's not just a coming in like past medical records, like, you know, a surgery they had, but a true, how do we notify, I guess, our team, especially for people like me, who they're coming back to me every time, and I'm going to be there with them once they get through, you know, this next pregnancy, they go through menopause, and they're having end-of-life discussions, and these things, and they come back up in end-of-life discussions. So, I don't know, just, you know, better way to give me heads up before I get sideswiped in the exam room.
Thank you.
Yeah, I mean, I think those are great points. You know, I think that, you know, unfortunately, EMRs do not flow like they should. They never do. And I mean, even for us, you know, I'll have patients that go in that one of my partners, you know, dealt with a miscarriage whenever I was out of town, and then I don't know until they come back in. I think those are very, very valid points. I think that, you know, one way that I've tried to combat that is that, you know, I'm in a very rural area, very small town. We don't have a large medical community, and so, you know, I pick up the phone a lot of times and call those providers and are like, hey, you know, Miss Sally had a miscarriage or had a loss, and you know, to try to follow that up. But I think those are really, really good points that I think as a medical community, that we do need to kind of share those experiences and to be able to document them appropriately. But you know, I think communication across healthcare is extremely important and extremely lacking in a lot of what we do. So I think those are really good points.
I appreciate a couple of things about that. One is that I think grief affects health. And not just are you going in the room, dad is in the room and calling that forward to mom, or to mom and dad, and letting them think through, oh, how is that coming to this? And then you can also ask, who is supporting you? Because that's part of healthcare too, right? I'm really interested in that question, is how do we make sure that care is not just stops at the clinic door, but as it leaves the room, where's it going to? Is it the grandmother that you live with, or that's down the road, or is it your church, or those kinds of things? And I'm really interested in how do we do that well? Just like marking the chart so that you remember when you go in that room. It helps, it can help everyone. Yeah. Right there.
Hi there. Thank you so much. Margaret Master with Healthy Mothers, Healthy Babies Coalition in Georgia. I think this conversation is so important as we address improving maternal health in our state. And I just wanted to highlight a couple of key things. One is I had the opportunity to review all pregnancy-associated deaths of mental health conditions, which includes things like suicide as well as unintentional overdose in the state of Georgia. And the profound amount of loss, both custody-related loss, as well as miscarriages, stillbirths, and infant loss in those individuals who had a mental health condition that caused a pregnancy-associated death was profound. And it may be that the pregnancy, the sentinel pregnancy was a healthy pregnancy that resulted in a baby, but the prior loss, whether custody, miscarriage, stillbirth, ended up, coming into effect profoundly. So I think that's something to keep in mind as we review loss and try to contextualize loss and support people in their loss. And then also reminding us a lot of what we've seen today is about the role of postpartum in addressing health. And so we're talking a lot about what's happening in that delivery room, about sending them home, but individuals who had a stillbirth or a late pregnancy loss very much have a physiological pregnancy of a postpartum period that they have to deal with, both medically and all the same risks, and being able to attend a postpartum appointment in a respectful way that they can go to that doctor's office and not see every mom there with their baby if they just suffered a loss is something that we need to just think about tactically, but how we make sure moms with loss get that postpartum care. And then lastly, I'll just say that there's real policy implications here as we think about the way that loss is incorporated into our leave policies. Again, if you've had a baby, if you've been pregnant for 9 months and delivered a baby and then don't have your full pregnancy leave because it wasn't a live birth, even though you're physically and emotionally dealing with all those things. So there's opportunities as we drive policy to understand what these types of losses mean as we think about maternal health in our state.
Yeah, I think those are really good points. I think that, as a clinician, that's one thing that we have brought up in our office on, whenever we have these moms that come back who had a loss, trying to flag those starts so we can get them back sooner. That's one thing that we've tried to implement in our office so that, they aren't sitting in the waiting room with 10 other expecting moms and kind of going through those emotions kind of still over. That's one thing that we've tried. It's difficult. I'm having to see patients back after they've had a loss, whether it's a third trimester or first trimester loss, and I only have one office space, and so I think that's really difficult, and it's something as providers that I think that's important for us to think through how we make that easier for patients, and that's one small thing that we've tried to do. I think the other thing that you mentioned was future pregnancies and how it impacts. I've got a patient now who, she had incompetent cervix. She lost both of her first two babies at 18 and 20 weeks and then ended up having cerclage. And I was able to deliver her third baby very successfully. And she's had another one. She's pregnant now, actually, for the fifth time. But I remember after she delivered her first baby, whenever she came back to me, she's in tears in my office. And I'm like, going through postpartum depression, going through all this, and she's like, no, I'm extremely happy with my baby. I'm happy that I'm having this, but I'm grieving that I didn't have this done sooner. And going through that grief process, I think it's important for us to realize that even though patients may have a successful pregnancy and have a baby and a newborn baby, that they're still grieving those losses that they've had before. I think that's a very deep, raw emotion that we've got to realize. And I think your point with legislature on, time after loss, I think that employers do a really, really poor job at recognizing that. If somebody had a baby, we planned on it for 9 months, and it's like, oh, you get 6 or 12 weeks or however long, the policy is to take off. But if somebody has a miscarriage, they're expected back at work pretty soon, and even if they have a loss in the third trimester, we don't have policy in place on FMLA to take that time off to grieve. And I think it's really important. So thank you for that.
Dr. Kelms, I wanted to just add a couple of things. I really love the point that you brought up about sadness and happiness can coexist. And I think sometimes when moms do have a subsequent pregnancy and they have a successful outcome, they're kind of torn because they're happy with current, but they're still missing the previous. And if they are happy with this one, does it mean they're discrediting what happened before? And so helping them work through that, I think, is really important. Also wanted Chaplain Byrd to recognize what you said about, I verbalize with my moms about a miscarriage. It's not your fault. I make them say it back to me.
Yes.
Because they don't say it, but they think it, and you feel it. And so putting it out there and getting it out helps them with that recovery, because they are always looking for a reason why that happened. Real quickly, I want to mention the physiologic thing that happens for someone that's had a late loss. I was pregnant with my son, 36 weeks, and I had to deliver an IUFD, intrauterine fetal demise. It was about the same, very traumatic. I remember that, and we asked her, did she mind that I was in the room, because I would be delivering her and I was also pregnant. And we had made a connection, so that was not an issue for her. But when moms do have a late loss, they will still lactate. And so we have to be very mindful of that. They have no baby, but they have milk. And so that postpartum follow-up needs to be very directing about how we manage that, if we're going to help find the breast or if they want to donate their milk or whatever that looks like. But that is adding insult to injury almost, because they're having all the postpartum things happen. And so just being able to recognize that if you do have patients going through that, we have to address all those recovery things that would happen, but there's no baby. And the last thing I would mention is, really losses is hard if it's 6 weeks or 6 months. And so sometimes there's a tendency to, well, you weren't pregnant that long. So, get over it. It doesn't really work that way, because it's an attachment. And even if the pregnancy was not desired, it's still a loss. And the other component that I think gets left out are ectopics. They're like traumatic losses. They come in, sometimes they're ruptured, 3 liters of blood, and things are crazy, and they have surgery. They may not even know they were pregnant. So that's a whole other level of interaction that we have to be thoughtful about. And the last thing I'll say is, I had a miscarriage when I got pregnant the first time, and I was terrified when I got pregnant the second time. So when you are dealing with or helping the patient who's now pregnant, their heightened sense of everything may be annoying, but that's their coping mechanism, because there's some lingering PTSD. And so it's really hard to untell people that you're pregnant when you're not. And so when I got pregnant with my son, I did not tell anyone, my husband knew. I remember I went home to Jamaica to see my dad, and he was like, "What's wrong with your tummy? You look like a little goat." It's funny, because I was real slim and it was just belly. But I was so terrified of it not working that I did not even want to be happy that I was 20 weeks, because I was scared that I was going to get hurt again. So I'm sharing all of that because I think that we have to, not everybody that you take care of, you would have been in their position, but it's really important to really kind of think about those things so you can help them work through that or make the right connections. And sometimes just naming it, even though you can't change it, will make a difference. And so just wanted to add a couple of extra points.
Thank you. I want to, as a chaplain, name something that you said and that is an undercurrent of this conversation. And that is the power not of what we say, but how we listen. We make meaning by the stories that we tell ourselves. That's how we do that. And actually, in telling the story, we need to verbalize it. We can't do it to ourselves. We have to verbalize it to someone else. And let me tell you, the power of a clinician or whoever listens well, not by speaking, but in listening well to someone making meaning, changes that story for forever. One of the psychologists that I love so much, Bruce Peardy, says, whenever we tell our story, we open the file to edit. So we give people the opportunity to make meaning and to amend that meaning. So when you say, and tell me it's not your fault, verbalizing it matters. Likewise, we got to be very careful that we don't put our meaning on other people.
Yes.
Watch what you say. It's only 6 weeks. Oh my gosh. Everything happens for a reason. If I could smack every person I hear and say that. God wanted another angel. Anyway, so thank you. Yes, who else?
I was going to add too, real quick, one thing that we also do, in talking to them about loss, is also plan for the future. That's one thing that I try to emphasize in my early appointments, or if we have a loss, is, after we kind of get through the grieving process, usually on follow-up appointments, it's like, how are we going to plan for this in the future? And with early miscarriages, I'm always very cognizant, let's get you in early, let's follow that HCGs, they've had multiple, we're looking at phospholipid antibody syndrome. And then with those later losses, I think it's really important to comfort those moms because they are scared. I mean, they're terrified that we're going to have another loss. So I think it's important to say, listen, we know this happened, we recognize that this is what we're going to do to plan for the future, to try to minimize it. And I think that's another important aspect of it, is that we want to remember the baby that they lost, we want to remember the pregnancy and validate that, and we also want to plan for the future to give them an outlook, give them hope that they can have a successful pregnancy and have a child.
I'm really enjoying this. Again, my name is Cheryl Burnside, and last year we had a 6-week program for pregnant women on Zoom, because some couldn't attend, so they'll know everything to look for during their pregnancy. Unfortunately, one of our mothers had a stillborn, and I remember I was pregnant 4 months, was told couldn't hear a heartbeat, but I was never told I had to wait until I had a spontaneous abortion, which happened on a Saturday, and I was told to go back to work on Monday. And I thought, okay, I never grieved because I immediately got pregnant again. I said, my clock is ticking. I don't have time for this. But it made me who I am today, to make sure every woman is educated about her health and her wellness. So this maternal health, when it started coming up, it hit so close to home. But this is helping me to make that call to this young lady. And because when she first told me she had a stillborn, I just said, listen, sorry for your loss, but she's still out there. And now I know, because I got kind of teary-eyed when we were talking about the 4 months, because I was like, that was me, although it was years ago. So thank you, I appreciate it. And now I know to make that phone call and ask her, who are you seeing, or who is helping? Do you need some mental health counseling? Because she was so excited about this baby. And thank you. I appreciate that.
The topic of grief is uncomfortable. The length it takes to really grieve is extremely uncomfortable, and we have institutionalized those discomforts by saying, come back to work, act like it's okay. One of the things that we can do, and I want to continue to push, is we can only be one elephant, but we can help people think about who are the people that can come alongside them and to support them. I think a deep reservoir of support people is a privilege, and not everybody has that, but we can help people build that. And I think we do have to be a little more creative about how we do that, and normalizing that this grief is going to take a while, it's going to be a part of your life. Let's make sure we don't let it make you have to deal with it just in isolation.
I think another important aspect that we haven't really hit on very much too is that it's okay to grieve as a healthcare professional. That's something that a lot of times we don't allow ourselves to grieve, and I think that's something that's really important and impactful. And I think that's something that we leave out of that conversation a lot. I still remember the very first loss that I ever had, as a resident. Had a patient come in, hit the door, heart tones in the 30s, rushed her back, got back for a C-section within 5 minutes, had baby out within a minute, doing chest compressions, and baby died. And I remember walking out of that C-section and being ready to quit. Can't do it. And having one of my attendings, who I respect and admire, come put his hand on my shoulder and just like, Justin, you did everything. Like, there's nothing else you could have done. You did everything right. Sometimes it happens. And I think that, as healthcare professionals, a lot of times we have to kind of suppress those emotions to move past and to go on to the next patient, because at the end of the day, my shift's not finished at that time. I've got 5 other patients who are laboring, but I think that's important as healthcare professionals to realize that and to allow yourself to grieve too.
I have a challenge to us as for 2 more roles in this, is that when we think about grief and loss, I'm Christy. I'm an old labor and delivery nurse. I'm now an educator, but I am also a parent of a significantly handicapped son who's bedbound. And I would challenge us that we need to think about the loss and the grief of normal, and think about those families. It took me years to realize that even my husband was having grief for the loss of normal. And think about our moms. You talked about the one at 21 weeks. There are those whose babies do live, or our families that have autistic children. That is a huge loss and grief of a normal life. And that is years and years and years of loss and grief of normalcy. So I challenge us to think about that. And then the other thing I challenge us to think about are those of us in the room. So in OB, we are a small world. And I can promise you, I probably know somebody who works in the majority of your hospitals just because I've been doing it for so long. It's a small community. Not terribly long ago, I heard of a small hospital in one of our rural communities in Georgia that had lost a mother. And I called my friend, Dr. Callens, and we had a conversation about it. And by the end of that conversation, I was convinced that she was going to have a life-flight helicopter at my door picking me up to go hug on and love on the staff members that were at that hospital. She said, Christy, that's it. I need you to come up with a staff team across the state of Georgia that we can go love and show support for those of us in this room when we have loss and grief.
That's powerful. Thank you. Thank you. It's never lost on me that it doesn't matter how rural your hospital is. People come in crashing. Babies come in really sick, and there's nothing you can do, and it's overwhelming. Yeah, thanks.
Hi, my name is Alexis Taylor, and I am a holistic birth doula. Also a graduate of the Morehouse School of Medicine Perinatal Program. And this is something that we had to do with our assignment, our doula assignment. We had to find churches that offered programs for bereavement, those who had lost babies. And that was the biggest challenge I believe that I had in my assignments, because I could not find churches in the Macon area, nowhere close to Macon. I think I found one in Athens that had one once a month, that they worked with women and families who had lost babies. And I would just like to see, since we're talking about spiritual, the spiritual aspect, as well as the mental and physical aspects of a loss, that more churches could be involved in giving bereavement classes or groups, whatever, to help families in those situations. Not even in the hospitals did I find that there were, such as yourself, chaplains who were there to perform those type of services. And I know that there are lots of bereaving mothers, fathers, families out there who have lost a baby at whatever time of that pregnancy that they had, who are in need of those services. So, sir, if you could, speak with some of your colleagues in the ministry and just let them know that this service is very needed and vital in our communities.
In Coffee County, I contacted Dr. Peterson, and then we together met with other physicians and ministers in the area and had this conversation, not so much about grief, that was one of the things, but do we know each other? Do we know each other's story? And do we know each other well enough to say, when we notice a problem in our community, ask how we can work together? And so I'm going to push that right back on you. And to all of you, if you know a clinician in your area, if you don't, do what happened to me in the back when I said, hi, you're my hero. I got, what's your contact? I need your number in my phone. Make partnerships and think creatively about these issues. Build circles of elephants for these people who are at risk. Tell each other your stories. One of the pastors who is my friend there was talking to me about his grief and said, I've got no one here to talk to about this. We can make these things open and care for one another, and it'll make our communities better, and it'll make our moms better too. Fathers too, yeah.
I think the one thing that helps in my office is that my nurse, her husband, is the hospital chaplain, and so it makes it very good because he knows everybody, and he's one of the ones that, you know, has been on the forefront to call our patients to know, and I think that it speaks volumes to our patients for them to know that, and you know, we can share information with him and tell him about who's had losses, because a lot of times patients don't want to reach out, and so I think it's also really important as a healthcare professional to have someone like that you can have that contact with and have that personal relationship with, to say, hey, Miss so-and-so had a loss today, you know, can you follow up with them or call them? And you know, he's awesome, and I think that we need to do that more.
I'll just add a couple more things, Dr. Chaplain. So in the hospital setting, we can always call the chaplain to come to the room of a mom where there's a loss. And so if you have a chaplain, you shouldn't have a chaplain in your hospital if there's one in the community. I've done that before, so don't be afraid to make the call, ask the patient if it's okay. And usually at that point, regardless of their faith, they're just happy to have someone to talk to. And so if you get their permission, that's perfectly fine. Dr. Peterson, so pilots have trauma leave. You know, when they have almost a near miss, they get like 90 days off. We get like 9 minutes. And I remember Christmas, I was in Albany working, and I delivered a mom, C-section, beautiful baby, and then I had a call at Palmyra Hospital for a loss. The mom went to the bathroom, the baby came out 23 weeks in the toilet. And so I went from like super happy to super sad, and then still on call for 24 hours. And so we do have to have a way to recuperate so we can continue to take care. And so compassion fatigue and grief that experience is really important. Last thing, there are bereavement doulas specifically designed. And so we do need that network so that we can call on that doula support for the moms who are grieving. The last point is women who have, for whatever reason, a voluntary interruption of pregnancy. Let's not forget, those do still occur in other states, and they live in Georgia. They also need that support.
Right.
And so regardless of the circumstances for how or why or whatever, they are trying to move forward, and that is an easy physical decision, but the emotional part of that is not always considered. I also have patients who have, for example, I have a patient who is bipolar, And whenever she's in a manic episode, she forgets to use her condoms. And so she's had multiple terminations, but it's also a subsequent, I guess, a side effect, I guess, or consequence of her mental illness. And so part of our management plan has been to have her see a therapist and then get on a long-acting reversible contraception. So it's not our place to judge. I mean, that's not what we're supposed to do. We're supposed to help people move forward. And so just thinking about that, the voluntary interruption of pregnancy, they still need that support and that healing as well.
I think one other point I wanted to make was whenever Paul and I first started talking about this conversation, we started talking about it in light of having a medical student come in and look at how the medical student can make an impact in the community in a short period of time. And one thing that we talked about was that after a death, especially a late trimester death, is that you have to have conversations with patients, not only about delivery, but care after that. Whether that baby is going to get cremated or have a funeral, or if they don't want to deal with it at all, or if they want to take it home. I've seen all of that. And, a lot of that, there's costs associated with it. I think one thing as providers that we have to think about is how we can best counsel our patients in that to make those choices, because that's really hard. I mean, they just had one of the most devastating things that they had, and they have to turn around within a very short period of time and say, oh, can we afford to spend thousands of dollars for a funeral, or do we cremate, or do anything with it? And so I think that's another important aspect of the conversation that we need to have, is that as a medical community, I think it's our job to have resources available for patients. We had a funeral home that was offering to do free cremations for any child. That was awesome. Unfortunately, they've had some issues, so they're no longer in business. But I think that there are things that we can do as a community to reach out to some of the funeral service to be able to do some of those things. Whenever that was offered, that was great for parents. Other things that we have to look at is a lot of parents have these questions on why did it happen. Every patient that has a loss is, why did it happen? And we talk about first trimester losses on not knowing, but a lot of times when you have later trimester losses, we have conversations about autopsies with babies. That's one of the recommendations. We also can do placental blocks with microarrays or doing amniocentesis. Unfortunately, a lot of times in these rural areas, like where I'm at, we don't have a lot of these services. I don't have a pathologist that specializes in looking at infant death. And I think, as a state, as a community, that would be an awesome project for a medical student to be able to come in and to look at that. I mean, and just as a community as a whole, to be able to come up with resources that we can provide for these moms in their time of need.
I think we are at our end of our time, but you've got a Baptist preacher here, so I'm going to take my opportunity to say thank you. Thank you for this, what I think is a sacred conversation.
Yes.
One of the things I learned in my work with rural communities and physicians as well as health leaders is that every one of us come to this because we feel called. It's not an accident. So hear this blessing as we go. The work you do matters. It is truly a matter of life and death. And as we do this work, may the difference really resound bigger than us.
That's right.
Blessings.
I told you we saved one of the best for last. I truly think that this is one of our favorite events that we have. And we always have great speakers, we have great food, we have great attendance, but it's you all in the room that make it. And that's what makes it special, and that's what makes it great. It wouldn't be nearly as good if it weren't for all of you and your perspectives and your comments and what you add and what you give to each other and to the conversation of maternal health in our state. And so I'm grateful for all of you. It's no easy thing to get out and come to these. We know you're taking off important time in the work that you do, so we're grateful for you and what you do every day. I just want to say, please take time to do the evaluation. It'll be part of your credits. You will need it for your credits if you're looking for CME or CNE credit. But also, it'll help us to shape what we do next year. We are going to do this again. We're already setting the date and looking at times where we will do this again next year. So please put it on your calendar. We'll let you know what it's going to be. As they used to say, same bat time, same bat channel. I'm aging myself a little bit with that one. But we hope that you will come and continue to be a part of this conversation. We also hope that you'll tell your friends. Please come, be a part of this conversation. I think a lot of things, we were making notes furiously throughout this room. I know everybody has something written down on a pad, on the back of their agenda, something. I encourage you, that's your action item. When you leave here today, don't just let it be a great day that you came and you did this. Do the thing. One of my favorite doctors says, change happens at the speed of trust. It's her. Because not only do I respect and love her here, she's my doctor too. So I do what she says. But she's right. Change in your community happens because they trust you. Change with your patients happens because they trust you. We can all get up, legislators can say this, rock stars can say this, pop stars, celebrities, doesn't matter what they say. We've done study after study after study in the center about who do you trust, who do you believe. And it ranges from vaccines to healthcare to stopping smoke, everything. They believe their doctor and they believe their healthcare provider. They know you and they trust you and they believe you. So do the things that you wrote down for your action items today. If something stirred you, if something moved you, if you said, I need to go call so-and-so, please, please don't let Monday come around and you haven't reached out. That would be the greatest thing. If every one of you go out here and do one thing for maternal health, we will change the state. We really will. All it takes is that one connection. Like Dr. Callan said, let me get your contact information. She has the busiest phone I know of on this planet. And she will not hesitate to call somebody up with a resource for somebody and to help somebody. That's how you create legacy change in the world. So I encourage you and I challenge you to do that as you go forward this week. So thank you for being here. Thank you for everything that you do every day, for how you care for moms and families and communities out here in Georgia. Thank you. Please make sure you do the evaluation, and we hope we will see you again next year.